right, cool. Welcome to the Strength and Chiro podcast. This is season 2, episode 4. And today we have two absolute legends. Very, very excited to have these two guys on. Both of them from a similar background in ways, and both of them doing similar things now in ways as well. So it's going to be a fantastic chat. Down in the right corner here, we got Dr. Christopher Marvin, or, you know, you could put Marv in the middle there, I feel like, because that's what's on social media. Maybe a Dr. Christopher Marvin. And so welcome to the podcast, mate. How you doing?
Fantastic. Thank you for having me on.
It's an absolute pleasure. And then we have Rob Cox on the left corner, who, again, is an absolute legend, and we're excited to have a long-time listener of the show, which is cool. So you're going to be able to listen back to yourself on this one. Welcome to the podcast.
Hello. Thanks for having me.
And, of course, as always, I call him Redmond, but it's Redmond. Dr. Stephen Redmond, welcome to your own show. How are you doing, sir?
Thank you. I'm doing great.
Well, it's always good to hear that. Where's your dog? What's the location of your dog? Let's check in with the dog.
He is right behind me. Right.
We need a separate camera just on the dog.
We need a dog cam.
So what I'll go ahead and do is I'll get you guys to introduce yourself and give us a little bit of a background on who you are, what you've done, your history, and what you're currently doing. And Rob, you can go ahead and go first, and then Dr. Marv, you can follow on after him if that's cool.
Okay, so I'm Rob. Really, I've come from a bodybuilding background. So I spent 10 years competing as a bodybuilder. And in that time, I was having, obviously, chiropractic adjustments. So I was actually using a chiropractor, not an osteopath. I was having soft tissue, and I would have quite a lot of it, to be fair. It was quite important to me to have a lot of this treatment. So then, you know, I really had a couple of people who I felt could help me. And then they moved away or stopped doing it. And then I just thought, well, hang on, like there isn't really much here. There isn't really much great therapy available. So I think I could do a better job than what's out there. I've already done my soft tissue courses. I've done several soft tissue courses. And then I found the John Gibbons courses, and I went and trained with John, which was really, really good. It's quite unique in a way because he takes you to the next level. He makes a complicated subject simple. That's the best way to describe him. So then after like most people who come on, they sort of say that whoever they were sort of inspired by, they go off in that direction. Had it have been a physio, I'd probably be a physio. I'd be training as a physio. So after I did all those courses, I just thought, hang on, I'm going to become the real deal, basically. Yeah, that's one of the best books. I use this book all the time.
Fantastic.
So then at 39 years old, I enrolled on the degree to train as an osteopath. And here I am now, starting my second year. And I just think it's a fantastic career to get into. You know, I'm just so pumped about it all the time. I'm just so fascinated by it all the time. I'm not saying there isn't difficult moments, but I'm absolutely loving what I'm doing, which is what you can really ask for.
I love it. Thanks, man. Dr. Marv, go ahead.
So my given name is Christopher Marvin, but I do not go by that. I go by Marv or Dr. Marv, whatever you prefer. Yeah, I did my undergrad in exercise science, worked in a physical therapy clinic in a hospital during that time. Thought I wanted to be a physical therapist. Then I started making too much money in the fitness industry to really keep going with that. So I did that for a while. Then I had some lifestyle things I needed to work on and improve. Once that happened and I got my stuff together, started my own independent training studio and online business. So I quit working in a corporate gym and ran my own thing. I did that for a while, then decided I didn't want to be, as much as I loved it, I didn't want to spot people in my 40s, and decided I wanted to go back to school. Turns out, apparently physiology had changed within the 10 years it was my undergrad to applying to go back to school. So all PT schools wanted me to redo my entire undergrad degree just to apply. That didn't sound too appealing to me. And then realized that a chiropractor helped me more than all the physical therapy I went to, because I've had 9 surgeries. I'm putting off a few more. The trend was some of it was genetic. Some of it was a very, unfortunately, cut-happy surgeon, and I had a really, really bad accident. So those 3 things kind of blended together. And I'd have a surgery or have a health condition, and they would tell me to stop doing what was causing the most pain, and I'd listen to that majority of my life. So at first I gave up soccer as a young kid, then I gave up basketball, then I gave up triathlons, and I gave up playing guitar. And then whether it was like childhood insecurities of getting picked on and being scrawny and wanting to keep lifting weights and getting big, when they told me to quit lifting weights, I said, hell no. there's got to be a better solution than just quit doing what you love. And then I realized, so that's why I wanted to go into physical therapy or chiropractic. But then when I realized chiro helped me way more, than I found this awesome chiropractor in the Bay Area, Dr. Justin Brink, who's, like a hard, like sports chiro focus. I didn't know chiros did that because the chiros I went to were typically straight. So like laser, adjust, a little bit of soft tissue. And I realized, wait, you could have like a full blown gym in your office and have people work out and they'll pay you to do that. But you don't take insurance. Like, that blew my mind. And within 4 months, I packed up all my stuff and moved from San Diego, which is where I'm from, to the Bay Area. My woman stayed behind in San Diego because she was going through cancer treatments. She's in remission, but she was going through cancer treatments. She went back to school. So we both went back to school. So I went back to school when I was 33, sunk my life savings into $250,000 education. I'm now in Seabrook, Texas, which is Houston Bay Area. I'm the co-owner here at Coastal Performance Chiropractic, and I'm the full-time performance chiropractor. I still do a little bit of online coaching on the side, but with all these new behind-the-scenes projects I'm hopefully going to be able to announce in the next couple months, I'm realizing I might have to give that up, as much as that sucks, because I love training dedicated people for hypertrophy. But yeah, that's my way too long introduction.
No, it definitely was not way too long. And so you got told to stop playing. I mean, okay, I know doctors, we talked about this yesterday, me and Stephen, and I know doctors often, if they don't understand, if they don't have a great depth of knowledge with anatomy, physiology, applied biomechanics, they'll just say stop lifting. 6 weeks, stand down, cortisone shot. I understand they do that. It's not, I don't agree with it, but it happens. But I draw the line when someone tells you to stop playing guitar. Come on. I played guitar I still play guitar, but like straight out of school, I went and trained as a musician. That was my life. I toured, recording sessions. I played guitar, all that stuff. If someone told me I couldn't play guitar, I would be so pissed. So when you said that, I was like, for one, why? And for two, like, how hard was that? And do you still not play?
I could play about 20 minutes at a time, which is better. I didn't play for years. Yep. I've got a bad wrist. This isn't a sob story, but I've been in pain since a young kid from surgeries gone wrong. And my wrist injury was initially mismanaged. So it's going to be a career ender basically. Right. So the wrist is an issue. So I have to balance working out for mental sanity, working on patients, doing all my online work and playing guitar. So I could play about 20 minutes twice a week, which is better than what it was. I would love to play more. Cause like I took lessons for 8 years, starting in the second grade. Like, that was my thing. I didn't go to the extent you did, but like guitar is my best therapy. I say lifting is therapy, but for me to get centered and totally in like, autonomic nervous system flow state, it's guitar. So at least I'm up to 20 minutes twice a week, which is better than nothing. And I've got to be grateful for that.
Yeah. The lifting therapy thing, like I get that. And for me, it's definitely like that. But I also, at the same time, there's been times in my life where I've been too far that way, and I've had to stop. I've actually had to stop going to the gym because it's almost like when I step foot in the gym, I become so competitive with myself. I get so caught up in the numbers. If I'm not where I was, it upsets me. If I'm not the size I was, it upsets me. If if numbers are going down, it upsets me. And I get in there and I just want to go crazy. And it's just like, it puts me in this mindset, right? Because I was in that mindset when you're trying to take down records and you're trying to take down world titles, you just have to go there mentally. And then now that I'm not competing, it's almost lost its therapeutic benefit. Like I still enjoy to train, but it's like, I got to be careful I don't switch too far over when I'm not a competitive powerlifter anymore to train and act like I am. That's the differentiation for me, and I got to be careful. And so guitar for me, like you said, that's kind of that whole autonomic side of things, that whole kind of grounding side of things. It's a beautiful thing, man. Music is awesome. Don't you play an instrument, Steve?
I do. I play guitar.
Mm-hmm.
I thought so. And do you have an acoustic with you where you live?
No, I have an electric guitar. I used to have an acoustic. I don't know what happened to it. I think I gave it to someone.
Nice. Yeah, I'm not sure how familiar you guys are with guitars, but I've got a beautiful Taylor acoustic, one of the greatest guitars I've ever played in my life, which sits in the corner there. And I've got my son owns 3 guitars. Not that he's old enough to really know how to play it, but I just tune it in a way that he just has to play the top note. So I just tune it in a way that everything is. So it's not your classic tuning. And then downstairs I've got my Les Pauls in one part of the house, my Casino, which is what John Lennon played. Single wound, widely wound coils, beautiful, sounds fantastic. That's in another part of the house. I've got a beautiful Gretsch in another part of the house. So yeah, it's still very much a big part of my life. But when I was studying, I did have a lot of friends that had to stop playing because of carpal tunnel or just wrist issues, and it was kind of like that thing. Anyway, that was a side talk. Carrying on with the theme of what we were just talking about, I'm going to read out a post that I saw yesterday. I just want to hear what you guys thoughts are on this. So I was clicking through social media. I don't know who this person is. Obviously, I follow them. I don't know who they are. Sometimes I just follow people back. I read this and it kind of just made me a little bit gutted for this person. So I'll read it out and I'll get your thoughts. So it says, bad news. Finally saw a doctor about my shoulder and bicep, and I have tendonitis in the rotator cuff and bicep. So not upper body training for at least 6 weeks. They gave me a steroid shot in the shoulder area and the biceps for the pain and spasms. Sigh. You know how much I love training upper body. This is a good lesson, though. Listen to your body. This was an early and fast catch. If I had kept training through the pain, I could have done some serious damage. Rob, what do you think about that? Give us your thoughts.
Well, the thing is with the whole tendon thing is that actually we all know that if you rest a tendon, it just degrades further. So some of I did it with my knees before I had any training at all. I was doing a hack squat and I think I didn't avulse off the tibial tuberosity, but it went black. So I pulled the actual tissue away. And I thought, I'll tell you what I'll do. My legs are massive. I'll have a year off training legs and I'll bring my upper body up. Well, they just totally degraded. And it was twice as bad as it ever was. At the same time, if that was like me, then I would have probably kept training on that shoulder and that bicep. True, you probably would make it worse if you kept training how you were. You'll probably make it even worse if you stopped. That would probably make that twice as bad if you didn't put any load through it at all. So, I don't know what everybody else's thought is. If you were to just sit down in a chair, basically, and we wouldn't do that, but rest it would probably just degrade further.
Yeah. And do you think it's like, is this a common theme that we see with medical professionals? Marv, do you want to touch on it?
Yeah, I'm probably treating 5 or 6 people with this exact thing right now. And this is going to sound harsh, but
I like it. Go for it, please.
I would get a new doctor. They obviously don't understand what musculoskeletal care is needed. We have to load a tendon to get it better, like Rob said.
I would too.
There's things you could do. So like there's an exercise standpoint. What's the culprit though? If you don't fix the culprit, which typically I find is poor shoulder blade control on that side and poor bracing on the opposite oblique, it's going to come right back once you realize when you go back, it's still there. And potentially worse, because then it's probably going to go from a tendonitis to a tendinopathy. Now you have the pocket of cells that are completely died off potentially. I mean, I know they did cortisone, but you've got to load it to get that tendon back to where you need it and not have nerve cells innervate it and all that stuff. You've got to find the culprit. What I do in office is shockwave therapy, dry needling, blood flow restriction training. So you can keep training the bicep, maintain strength and size, get the local soft tissue healing stuff going, work on shoulder blade control, you're going to have to probably temporarily modify stuff. So overhead, probably you're going to have to temporarily eliminate right? Work on other stuff, So again, yeah, it's super common with who I treat, because I treat a lot of powerlifters and CrossFitters and bodybuilders and high school athletes, right? So a good amount, I'm probably treating more to like 10 people with this exact thing. And half the time they come in and say, it was my rotator cuff. No, it's your bicep, right? So that's another misconception. But in my opinion, cortisone is a tool, but it is a tool that should be used after conservative treatment's done, or you do it to maximize it. Because once you get the cortisone, that's the time to rehab it when the pain is down. So then you could be aggressive with rehab versus get a shot, do nothing for 6 weeks. This person's probably going to be in a much worse scenario, like Rob was talking about 6 weeks from now, than they anticipate or even know.
Yeah, so it's clearly, the kind of the first point of care to be administering steroids and telling them not to do anything is probably, not probably, it's clearly not the right thing to do. Dr. Stephen, do you have any thoughts on this?
Yeah, since we just talked about that last night.
Funny that.
And so I was like, yeah, like what's going on? Like the person's not going to be able to use their shoulder for 6 weeks. Like, how's that a fix? And I wasn't a big fan of the thought of jumping to the steroid for some tendonitis. which may or may not actually be the case. Who knows? Because we didn't examine the patient. But yeah, like if you're going to use the steroid, as I mentioned last night, you got to jump straight into the rehab. You don't just sleep for 6 weeks after you get the steroid. You've gotten rid of the inflammation. Now that you've got rid of the inflammation, now you can target the rehab for the right structures. If you don't, the inflammation is just going to come right back because the tissue's damaged and it's going to bring in inflammation. It's going to bring in fresh blood flow to repair it. And if you're not repairing it under load the correct way, it leads to chronicity. And that's where healthcare fails everyone.
Yeah, and especially like Dr. Marv was saying, if we start leaning towards the OSIS side of things, or degeneration or tissue death, that's something that is kind of changes the scope of what we're doing here. And I know I'm asking you guys to talk about just one slide. It's going to be contextual, but that's kind of part of the exercise. That's what makes it fun. But, tendons can be a different beast, and people are going to do different things. Oh, I was going to say goodbye to my son real quick. You can wave. You can say hi. This is Dusty. He's a big brother. He's going to be a big brother in November. Hey, bud.
Nice.
This is Rob, Dr. Marv, and Dr. Steven. I'm talking to them. They're all from different places in the world. Pretty cool, eh? I love you. Give me a kiss. Okay, have a good day.
See you, Daddy.
See ya. And everyone has different strategies. You know what I mean? It's like McKenzie, we're going to restore extension. Lehman talks about pushing into pain. McGill talks about removing provocative movements. Like everyone has their thing. And so it's just like taking everything and putting it together contextually for the right person. And like you said, Stephen, you hit the nail on the head. Like we haven't assessed this person ourselves. So it's hard. I know it's hard to ask you guys to give your opinion, but it's the nature of a podcast. So thanks for playing ball.
But I do want to say, I think it's important if you are somebody who's like in quote unquote physical culture to find a provider who is doing it or is familiar, because they're getting soccer mom Susie and John Doe, who's never going to rehab it to begin with. Patients they see on a day-to-day basis who aren't going to do anything, and that's what they go to. So find somebody who understands your sport, your needs, your goals. I think that's super important, because once I found that for myself, because I saw 30 different doctors for my wrist, and several of them told me I was making up the pain, which made me feel great. But once I found somebody who was like, could, sympathize and empathize and be like, okay, well, this is the reality. Let's work around it. Like that's important. So you might have to go quote unquote doctor hunting or provider hunting, which is unfortunate, but you've kind of got to take things in your own hand these days with healthcare.
People, if they see DR at the front of someone's name, or if you're an MD, or if you're in New Zealand, a general practitioner, GP, you go to them for everything. They're your one-stop shop for anything, when in reality they probably do not have the training or the expertise to be dealing with musculoskeletal stuff, and so that stuff is being mistreated, and that's definitely a problem. But the issue is there aren't that many great musculoskeletal people around, and we do this podcast and we're picking out of, we've got billions of people to choose from. No, obviously not, but you know what I mean? Like we've got all these people in the world that we can talk to, and it's scary how limited it is. Like how many people I see that I would actually be like, they're really good, or they're really good. And to be quite honest, in my own country, there's probably not one single person I would refer my mum to, or my sister, or my brother. You know what I'm saying? I would refer them to any one of you three, but so you guys live on a different part of the earth. So that's definitely an important kind of thing to touch on. And we do talk about that on the podcast often. So I feel like all three of you nailed it. So moving on, something a little bit more of a lighter question. What is it that you both really enjoy, and what is it that makes you get up every morning and go into work and do this job? Because there are many ways to get rich. There are many ways to make money. There are many ways to do things in life. And it tends to most people I talk to who are not, it's this weird spectrum, right? When it comes to with manual therapy, it's almost like the really good, genuine people are seeing less people and may not be stacking up the numbers and getting all this, making huge amounts of money. And then on the other side, you've got people that are seeing all these people charging crazy amounts of money, buying themselves, or driving around in sports cars, turning up to give, at chiro school. I'm sure you guys have, or at osteo school, I'm sure you may have all experienced this, but they bring someone in to talk to you about chiropractic business. They roll up in their Rolls Royce or their Porsche. They sit there and they start telling you how you got to have 100 patients a day, and how you got to get your times down to 7 minutes per patient. I've shared this story before, but when we had that discussion, the person that was telling us at chiro school, he told us he got his patient visits down to 2 to 3 minutes. So in a world where this exists, in a world where it's tempting for some people to do that and make more money or whatever, what makes you guys get up every morning? What makes you kind of, in a sense, continue to fight the good fight, be evidence-based, do things right, be ethical, and to help people? Marv, you can start us off.
Because what I went through was trash and nobody should have to do it. So I love educating people of what's going on. My initial exams are an hour with everybody, full stop. Right.
I like that.
So it's a bit of a thought experiment we're doing here in the office where we just bill based on time. Whatever you need is what you get, no matter what treatment modalities, whatever we need to do. And it's working, no, I'm not stacking up millions of dollars, but I think in the long, you do good work and help people, the word gets out, the money will eventually come. I've chased money in the past and was not happy. But providing people an alternative to the scenario we just discussed, helping people get back to their passions or keep doing their passions, right? Like when I'm doing a history, I don't give them a standardized questionnaire because who cares about a number on the paper? I go, why are you here? Like, what was your quote unquote pain point that you couldn't do something any longer that made you choose to come here and pay out of pocket cash versus going and using your insurance down the street? And so when people say, I got to do this again, or I got to do this again, or, they send me updates or whatever, it's freaking awesome. And I devoted my whole life to learning the human body. So if I wanted money, I should have done it elsewhere quickly. Right. I've been fascinated with it. I think it was, like I said, originally insecurity early on, and then realized, well, I've spent 15 years pretty much studying this stuff before going to chiro school and then what I'm doing now. I love the topic and I love the Rubik's Cubes patients where they failed everywhere else. I love that stuff, but just pop my neck real quick. I'd blow my brains out if that's all I did all day. Personally, different strokes, different folks. I'm not hating. If that's what you do, great for you. There's 31 flavors of chiro, and there's multiple flavors of osteo and PT and massage. They're helping people. Otherwise, they wouldn't have people coming in. But that's just not what gets me excited or what I want to do.
And fair enough. Rob, what are your thoughts?
The interesting thing is that Marv answered that almost exactly as I would. So even it sounds a little corny that you want to help people and things like that, but I spent a long time not helping anybody. So I was a cabinet maker. I was in a workshop full of guys that had nothing in common with them apart from I walked on the same bit of workshop floor for 8 hours a day. And I was really just a selfish bodybuilder. I wasn't selfish, but I was just had my head down. So the fact that I'm actually doing something worthwhile and trying to get people back to good health gives me a genuinely good feeling. So yeah, no matter what happens, the more ethics you have, the less money you'll make, unless you can get people to give you £500 a session. So yeah, what gets me up, I love, like he said, I love somebody who's seen loads of other people and they've had no joy. That's my ideal patient. Somebody where they've been everywhere, and then, and it's not that I'm so much better than those people, because if you've seen 5 people, 10 people, I'm not going to be much better. It's that I'm going to take time. I'm going to use my obsession with anatomy. And I said that if there's one thing that will make you a good therapist, clinician, osteo, physio, chiro, it's learn your anatomy, because all the other things will help you. But if you've got no map, then you don't know where you're going and you don't know what the action of that muscle does. So to me, like, I'm never bored. I get frustrated if I can't help somebody, but I'll start working back and I'll go over an hour. I'll be an hour and 15 maybe with the first person, and I'll just go back and back. And there's always something they're not telling you. No, nothing's changed. I've not done anything. If you just keep picking and digging and dig, they'll go, oh, well, I did. You'll find it. Yeah. And that, to me, the detective work, and to try and crack it. But I'm frustrated if I can't. Or maybe that person isn't even into helping themselves as much as I want to help them. I have some people where I care more than them.
It's cool because, like, you see patients get better and you see people be able to go back to doing what they love, and you're like, man, this is what it's about. This is fantastic. And just to throw to you real quick, Steve, your background is really similar to Dr. Marv's, and you've had frustrations around what you were told what you can do.
Yeah, so I was in a pretty traumatic car accident. My car went underneath one of those big, massive semi trucks twice on the interstate, and I managed to survive.
Yeah, wow.
And at the time, so in the US, we don't really have free healthcare, but I did have free healthcare at the time because my stepfather was retired military. So I had free healthcare. I could get all the things done, but it also meant I could be mismanaged so many more ways because they don't care. It's not like in the private healthcare industry where they get paid based off of their outcomes. No, it's military healthcare. Like they don't care. They're making a career out of doing as little as possible a lot of times.
Mm.
So I was mismanaged. I was misdiagnosed, further mismanaged, sent to different people, told that I was 19 at the time, and I was told just to get used to living in a life of chronic pain. And I do have chronic pain, but it's manageable. I was never taught how to manage it. I was told went through all the avenues. I fell PT. I had a consult signed up with the neurosurgeon, and I asked my pain management doc if I could see a chiropractor instead. And that changed everything. And
What kind of car was it?
he was a straight chiropractor. He's a gondroid,
It
but
obviously helps.
I mean that just shows that it doesn't take it's not like why you're doing it, it's what you're doing. So you could see a terrible person, and if it was the right intervention, you're gonna get results. So I thankfully saw someone who was competent in what they did, even if their philosophy was 200 years old. It still got me to where I was able to get on a skateboard again, able to go back to work, able to stand up for more than 2 hours at a time. Like, yeah.
So you had a spondy from the accident?
Yeah.
Yeah. I've got one, and people think it's a death sentence.
Yeah,
because
they
they're
do.
told it's a death
Even
sentence. They're
practitioners,
told
like,
it's a
yeah, patients and
like,
practitioners assume it's a death sentence.
yeah. Like I even helped a physical therapist who's a Highland Games competitor, and I'm like, okay, so you have it. That's not going to change. Let's figure out how to work around it. Like it ain't going to change, so it is what it is. But you just might be more susceptible, and you've got to be a little bit more careful. But yeah, they're way more common than people think.
Oh yeah,
in my opinion, and they're not a death sentence. They're not fun, but yeah.
Have you had any patients with anterior segments in the cervical spine?
Yeah.
My C2, when I was second year at chiropractic, my mentor came up to me and said, "Oh, we've looked at your x-rays. We need to talk to you." Taking me into the side room. I thought I had cancer. Like I thought I was so scared. And she briefly said like, "Oh, look, your C2 slipped all the way forward. This is why you're getting migraines. This is why da 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 da." Up to that point, I've had nearly 2 years worth of P to A thrusts into the back of my C2. Every time I left clinic, I felt dizzy. I had a headache. But people don't listen. They don't listen. Mentors don't listen. They think that you're being an arrogant little prick if you question them, even if it's on your own health. She was telling me about it, and then she walked out of the room, and I said to my student doctor, like, what happens if it keeps going? Like, does my neck slip off my head? And so I took the images, sent them to the best doctors I know. One of them was Dr. Mike Woodbury. I'm sure you guys have heard of him. A bunch of guys came back to me and said, it's fine. It's fine. Like, yeah, it's there. It's not super bad. It's there. Abide by the same principles you would put on anyone else. The Punjabi stabilization system, active neuro and passive. If there's a passive deficiency, you've got two other ways to strengthen it or to make it move more proficiently. So it's an interesting thought, like, especially with Gonstead, everything's a posterior segment, everything's being P to A. I know there are some anterior adjustments, but I never saw one happen once in the clinic. So it's one of those things. If you truly know how to assess, that would have been picked up immediately. However, it was left over years and years and years of the wrong treatment and me having symptoms from it. So anyway, I'll move on from that. Dr. Marv, so ever since I've kind of met you on social media, I have to say I'm very, very impressed with how you think. I'm really impressed with your intelligence. I love that you have a background in bodybuilding, because I feel like we can relate with that type of stuff. But I also love hearing you talk about biomechanics, movement, physiology. I love how you can take a movement and be like, you could do this movement and not think about it, or you could do it here. You could, tension length relationship of the muscle here, place your body here, get more out of it here. Love listening to those videos every time I click on them. And when I'm in the gym, I'm trying, I'll put my elbow here and I'll get a more stretch on the tricep or whatever. Being someone that thinks like you do, it's definitely one of your gifts. How important is it for you to relay your information or the things that you know to your patients? And to bring the question to a point, in a clinical setting, how important is education between the doctor and the patient, in your opinion, Dr. Marv?
That's my number one intervention, full stop, is education.
I love it.
Like, literally, I tell people, if you don't understand what's going on and what's causing your pain, or what we think is causing your pain, because I don't have MRI vision, and the best way to get freaked out is do unnecessary imaging, because we'll probably find something. But if you don't fully understand what's going on, then I failed my job. Full stop. When it comes to exercise, yeah, I meet them where they're at. Some people want all the details that I share in my tutorials. Other people don't. So I kind of pick and choose. But having that knowledge of functional anatomy and training biomechanics makes my life so easy when trying to give somebody an exercise. So I'm blessed. I've just been obsessed with it forever. And now, I see a good amount of bodybuilders and powerlifters and CrossFitters for a reason, because I can find substitutions or can find something to keep them training or strengthening an area. Like, if you never train a muscle in its length and position and you keep having little minor strains, well, why don't we start getting it resilient at that end range that it's never experiencing any length tension in it? And by the way, you'll probably get better gains with Z, because most muscles, not all muscles, grow from, stretched load. But yeah, I have to pick and choose because I can overcomplicate things. So I've gotten way better. When I first started, I used way too big of words, and now I try and use as simple words as possible. And if they have a background, then yeah, we'll nerd out and stuff. But also, I do find patients like the biomechanical stuff when I'm explaining it from a 10,000 point view. So, and now I'm getting a bunch of stage competitors coming to me with imbalances in posing. Like, this right trap's higher, I can't flare my right lat. Like, that's been really fun to figure out too. What I say though, let me end with this, because I don't want to answer every answer to be 5 minutes long. With my tutorials for hypertrophy training, none of it matters if you're not training hard. And most people need to work on actually learning how to train hard if you're trying to get as big and strong as possible, versus worrying about every little biomechanical nuance.
Yeah.
But for those who do train hard, those nuances can make a huge difference.
Absolutely. I mean, and I say to people, when you're really in the clinch of it all and you're trying to do something professionally, or even if you're just a weekend warrior, no disrespect. If you love it and it's something that is making your life better, and that's the mentality you want, fantastic, go for it. But for those people, people go, oh, it's the 1%. Bullshit. It's the 0.1%. Like, and I'm sure both of you can understand, and Rob, I'm sure you definitely can understand what that's like, especially when you're getting down to single digit body fat and you have to stand on stage in a G-string. It's like, hey, it's going to matter how my glutes look. Like, I got to feather out those glutes. But I love how Giles Guy, he goes, sometimes I can get people better with a great history. And it really just goes to show, man, education, paying attention, like you said, Rob, paying attention, caring about the person. And as you said, Dr. Marv, actually educating. And sometimes we can talk ourselves into circles. And I love what Aaron Horschik from Squat University says. He's like, look, simplify. There are people in the industry that talk in circles. You hear Aaron talk, it's always simple. He gets a lot of flack. People don't actually realize that he is super intelligent. He knows everything, dumbs everything down on purpose. That's why he has 3 million followers, right? Because he wants people to get the gist of what he is saying. At the same time, people will, hate on him for being too black and white or too simplistic or whatever. But when you're dealing with the masses, it's very difficult to have context and nuance. So it's just one of those things. Another one for you, Dr. Marv, being that, and we talk about this on most podcasts, and I'm not here to, like I try to say, I'm not here to, always bag on chiropractors, just when it's warranted. But in this situation, what separates you from your traditional chiropractor? Why is Dr. Marv different? And look, I've obviously the audience has already heard a lot of why, but I want to hear a little more from you. What separates you from your traditional, dare I say it, tour?
unfortunately, the majority of my professions, it is what it is. So, different strokes, different folks. If they're helping people, great. But for starters, I call myself a performance chiropractor for a reason, to try and separate ourselves, right? So very exercise focused, large tool belt. I don't adjust everybody. Adjustment's not always warranted. It is a very powerful tool. It's probably the closest passive modality we have with getting active results, and it's a powerful one. But if it's not called upon, or if it's not appropriate, you have a hypermobile person coming in and they've been slammed on for the last 5 years. Well, yeah, no wonder why you're hurting. You need strength and stability. You don't need no emotion. But the education focusing on big rocks. I do all the nutrition through the office. I've written a book on nutrition, my training days, way out of my scope, which I recognize now. But hey, I was in my young, late 20s and was trying to change the world. Having a large tool belt, having people send me videos of their workouts or whatever thing is hurting, or this movement hurt. Like I had a guy in here Friday. He's a power lifter. We're rehabbing a tendon issue, a bicep, and a rotator cuff, just like we're talking about. He's like, yeah, floor press is hurt. It was his third visit. I'm like, all right, we floor pressed in the office and we found a few things, made a few tweaks, and gone. Right. So focusing on patient empowerment and improving not just their complaint, but their quality of life and their health span by getting them to exercise. And I don't care if it's somebody who comes in and they're not the quote unquote traditional person you would see at a performance chiropractic office. They're, diabetic, severely overweight with pain. I'm like, hey, how about we just have you go for a 10-minute walk after meals? Because the research on that is pretty outstanding for diabetics with blood sugar regulation, let alone we just need to get movement, full stop. Right. So, and then, taking time. I would say 95% of my follow-ups are 30 minutes. The rest are 15. And those are people who are doing things on their own, or they want, quote unquote wellness care, where it is just an adjustment in soft tissue and, dry needling or shockwave or whatever. But majority of people are coming in and they're spending a good 5 to 20 minutes on our rehab gym floor. And we're going over what's causing their pain. And we're going over the big rocks and talking about sleep and what supplements are you taking? Great. Quit wasting your money, because you have other stuff that's a bigger priority. And being somebody who modifies doesn't eliminate as much as possible. That's why I'm really popular with CrossFit currently, because they go everywhere else and it's stop doing what you're doing. And I'm well, let's give you a warm-up routine that your body specifically needs addressing I never use the word dysfunction with patients. I think that's fear mongering, but different strokes, different folks. But I call them, let's give you this routine that focuses on your areas of opportunity that we found that your body's a little lacking in, and watch how you perform better, you feel better, you recover better, you're in less pain, which then allows you to go a little bit harder, which is probably going to make you happier. And then again, but not being adjust only, not being a name technique only, having a large tool belt, and also telling people, I don't know, it depends. Let's find out. This is what I think's going on paper in a vacuum. I think will help. I had a patient get surgery 2 weeks ago because it had to happen. I'm not going to fix a dislocated extensor tendon from an injury that happened 6 months ago. I can't do anything for that. Right. But hopefully that made sense.
It did. And I like how you say right off the bat, you're like, not everyone needs to be adjusted, because that's that thing that chiros cling to for dear life. It's that one thing they're known for, and they feel like they have to do that with everyone. And I think I've said this on the podcast before, but there's only a handful of chiros that I've asked and I've talked to that have said, I don't necessarily have to adjust everyone. And you got to have other tools in the toolbox, and you got to be competent. You got to be, you got to know that you can modulate pain in other ways if you need to, because you have to adjust on the moment for the person that is sitting in front of you. It's contextual, right? As we always talk about. So people that are like, no, it's fine, I'm just going to crack the hell out of every single person that comes through my door. That approach is not always going to be an accurate approach. As you said, it's not always the appropriate thing to do. Recently, doing a paper with Giles, we looked at, and I'm sure you've probably seen me post about it, we looked at the differences between manipulation and mobilization. And chiros don't usually want to hear it, but it's very similar, very, very similar. and you say that, obviously, spinal manipulation is very regulated, because you get that crack and you get that kind of release, and I know that patients love that. But it's really interesting when you look at the literature. It's like, whoa, how do we separate ourselves from our biases or what our previous thought beliefs? And sometimes I'll say to chiropractors, like, do you mobilization? And most of them will laugh at me. I've said it on the podcast before. When I was in chiro school, I got told that mobilization is just joint play and it should be used to assess and never to treat. Stephen was probably the first chiropractor I talked to and geeked out over mobilization because he's an LMT himself. So throwing this over to you, Rob, what are your thoughts on being on osteo? I know a lot of osteos do a lot of mobs or LVLAs. What are your thoughts about mobilizations? Where do they sit? Where's their place? Do you use them? And then finish off the answer giving me your three favorite interventions that you use in the office. So your three favorite modalities.
Okay. So, yeah, mobilization is a massive part of osteopathy. And like you're saying, if you are a one-trick pony and all you do is crack people and you give yourself 10 minutes, you're not really going to want to do much mobilization because hitting that barrier, it takes longer than cracking. Most of the time, I find it as effective most of the time, but there is that time where that just needs that equal force in the opposite direction. There's no doubt about that.
Yeah.
But yeah, like mobilizing. One thing I did find, just experiment on myself, really. Like when we were like in class, we were doing mobilization, and I was getting my neck mobilized, and I knew it as like quite locked on this side, and I was getting it mobilized, and after I'd had it mobilized for a little while, I thought, yeah, that feels really good, but I know it's there. So I just, I just put my neck around like that and up against the barrier. And it went so much easier than if it hadn't been mobilized. So we used to get taught, or I've been taught this off other people. Someone comes in, maybe, what would you do first, adjust or mobilize? And usually they'll say, well, if you adjust, all the muscles will calm down, then there may not be necessary for you to do as much mobilization or tissue work. But actually, by just experiment on myself, actually, it's much better to do the mobs and the massage first. And that adjustment is a lot less brutal. Because when somebody's getting their neck twisted around that far, so when I do any type of adjustment, I'll probably only move. When they breathe and you side bend, and then as you just bring it into place, it goes, but you didn't actually do a thrust. So that's my sort of thing on. I love them as a as a warm up to that adjustment. It's far, far better than trying to snap a facilitated neck with a facilitated muscle. So my favorite three, I always use METs because to me, that's the nearest thing to exercise that isn't exercise, really. Because you can use them to strengthen in really weak people, not strengthen, but to turn on to get that sort of contraction going. So always use an MET. Very rarely will I treat anybody and not use an MET.
So just to interrupt quickly, MET for those that are listening is similar, is the same thing as PNF.
Yeah. So same as a PNF. Probably a little less brutal than a PNF, to be fair.
A lot less brutal.
Yeah. And soft tissue is another one that gets a bashing. And for me, why does it get a bashing? Usually off a physio. Because if you're not that good at it and you don't use it, you're probably not going to like soft tissue. To me, it's one of the most powerful tools in my toolbox. People don't want to do it because it's expensive for you to do. It takes time but to me, it's one of the most important things for down regulating pain and getting that person in a position to be able to do their exercise. That is, to me, one of the best things. And let's face it, that's pretty much what you're doing with it. So I probably have MET, soft tissue, and it's got to be the good old fashioned adjustment, hasn't it? Like, let's face it, we can all say, we don't have to hear a crack, but don't we all want to hear it? We don't all have
It's-
to crap, but if you don't get one, you just keep jumping on it until you get a crap.
it tends to be like that, eh? It's like so many people chasing that audible. Yet we're taught that, like, you know, an adjustment is based on, obviously, like post assessment and objective outcomes. Yet people are crack hungry for the sound, not the drug. And it's very interesting how that impacts how people do social media videos and where they place the mics. Just drives me nuts, but we'll get to that later.
I want to talk on something that Rob said though about people just bashing soft tissue. Like, I think people they forget what evidence-based medicine is, which is, what does the research say? What does the clinician's experience say? And what does the patient want? Like, there's all this flipping, and I'm trying not to cuss because it's so aggravating. The research says this. The research says this is trash. The research says that's trash. You know, dry needling does freaking nothing, and it's usually a PT. And I'm like, okay, I recognize the research isn't great, but first of all, who's doing it? Like, MPI got bashed, right? Motion palpation stuff, all the studies, oh, you're not reliable. But speaking to some of the president of MPI, he's like, but none of our trained MPI clinicians were the people delivering the assessment in these studies. So that's interesting. Like, who's delivering it? It matters. But also, like, what is, dry needling has been an awesome tool to add to my tool belt, and it's blown my mind, right? But it's not appropriate for everybody. So, it's not, one trick pony ain't going to work everything. But people just forget, like, it's also, what is your patient like, and what is your personal experience as a clinician say? And people forget those other two parts. They just want to, and that happens in fitness, right? With this whole, all those PubMed warriors who've never trained, beyond pink dumbbells with a pinky twist because it maximizes the biceps brachii contraction and inhibits, but like, people forget, like, it's a 3-pronged chair that needs to be level so the chair is balanced. Sorry, that's been really bugging the hell out of me these last couple months. It's just like, oh my god, like,
and it's absolutely true.
Just throwing research,
and we get taught it in the first year of, like, on most of these degrees. Like, you get exposed to that, the evidence-based kind of clinical model, and it's never just only read the research. Again, like, Stephen, you hit the nail on the head last night. You're like, people come to see me, they're humans. Every person's a different person. Everyone's going to require a specific assessment. It can never just be one size fits all, right? These aren't just like shoe sizes for everyone. Everyone's the same size.
Yeah. Well, I was going to say, why do osteos and chiros have such good patient satisfaction? Probably because we put our hands on patients. Like, we know placebo is powerful. That's why primary care physicians usually have patient satisfaction, because they're in and out in 2 minutes. Simply putting your hand on a patient to treat, like, immediately improves outcomes. Like, I'm not going to do soft tissue. What? Yeah. So, anyways,
the biggest limitations with research is they can't experiment on everyone. Like, they have to use healthy people. They can't have people with certain medical conditions undergo research in case it doesn't go well. So when we're looking at research, we're looking at very specific demographic that was used in the sample size that may or may not reflect on the patient in front of us. Absolutely. And so research can guide us, but we have to accept the limitations of the sample size.
And that's always going to be a limitation, because we can use whatever calculation, we can use confidence intervals on population sizes to have a 95% certainty that that's going to be part of the population that we're trying to sample. You can do all this stuff. I've done it all. I've crunched the numbers 1,000 times. It's cool. But as you said, end of the day, the sample that's in front of you is the sample that's in front of you. It's very, very difficult to pick people out of a large population and do a couple of calculations and then say, yeah, it's close enough, 95%. So we really have to know where to place evidence or research on the hierarchy of how, in terms of how it makes us practice. And then on top of that, being able to appraise research is a skill that most clinicians do not have. And that is an issue. And so I often say on this podcast, read a study a week. If you can, read a study a day. if you can, read an abstract a day, read a study a week. Like, just get into it. Get confident and comfortable with p-values, confidence intervals, because when you glance at a study, when you're reading a study, these terminologies and these calculations are used to represent and to communicate a lot of information in the shortest amount of time possible. And if you don't understand that stuff, you find yourself having to read through the whole study, read every single word. You can get skilled at this. It's a skill. Reading research is a skill. Interpreting research is a skill. Applying that to your patients is a skill.
That's where I feel a little bit inferior at the moment, because I'm having to learn so much stuff that I'm just trying to fit in reading things like that as well.
Mate,
So
you're great.
Loads of stuff to read.
I would not worry. I would not worry. You are like so driven, so passionate, constantly reading things and asking questions. And I mean, like, you're always reading books, you're always reading studies. Like, that's where you want to be. You know, that's the slipstream, man. Like, you are just constantly growing. So I wouldn't worry about that. And hopefully, like, when you did Rob did a presentation on one of my studies, hopefully, like, we were able to break that down and make things a little bit clearer, because sometimes when you're looking at just all these kind of differential statistics, and it's just like, man, this is confusing. This is hard stuff.
Yeah, I've got them. I took all the terminology and I wrote what they meant. So I've got like PIVO, confidence level, single-tailed hypothesis.
Yeah, it's very helpful. It's very, very helpful when you need to look at things at a glance. But anyways, so I like how you call yourself a performance chiropractor, Dr. Marv. I have recently was talking to Stephen, and I had a perception that was very wrong, because I'm in New Zealand. Things are different here from America. I kind of always had the idea that people that call themselves sports chiropractors are like people like you, Marv. Like you are the sports character. But what I've come to learn, and Stephen explained to me, is really a sports chiropractor is a chiropractor that works in a sports team, and they are kind of just hired just to adjust. Is that kind of right? So you differentiate. You call yourself a performance chiropractor. Is that on purpose to differentiate yourself from someone else? Because really, if someone comes to me and says they're a sports chiropractor, I'll go, oh, cool. Like, can you have a look at my squat? Can you have a look at this? Can we do some kinematics, some biomechanics? Can you do that? And they're like, oh, no, I just adjust athletes. I'm like, oh, that's the differentiation. So it may be different around the world.
Yeah. So if you are a quote unquote sports chiropractor on an actual professional team, your only job is to adjust. If you are in private practice and you call your sports chiropractor, anybody could call themselves a sports chiropractor. There's a lot of sports chiropractors right around me. And
in some parts in some states, right? Because like Stephen was saying, you legally can't in some states.
Yeah, and it all depends. But then all you have to do is take a 100-hour outdated course that I'm actually going to do, because I need letters behind my name to get involved with certain sports teams. So
the CCSP, is it?
Yeah, I'm going to play that game. But anyways, but like, depending where you're at, you could 100% call yourself a sports chiropractor, and you could give them a TheraBand exercise, and now you're a sports chiropractor, right? But if you are hired on a team, like my business partner, he goes to the Olympics, he goes to World Games, he does USA Gymnastics. His only job is to adjust and maybe soft tissue. He's not there to provide exercise. He's not there to, unless they ask him to do something. Like, you stay in your lane, you don't deviate. You're a cog in the wheel. Just like at the VA, all they do is adjust. And in most interdisciplinary clinics, like, the chiro only adjusts. Right. Yeah. So it depends where you're at and what your role is. But for the most, in my opinion, take it or leave it. I'm not the end all be all. Right. I'm not the world's best chiropractor. So from the outside looking in, as somebody infantile in this profession who has a long way to go, most people who call themselves sports chiropractors aren't justifying it. And I could get a lot of flack for that, but yeah, it's trendy, and a lot of the stuff they'll do and call themselves sports chiropractors, like, all right, if that's what you want to call yourself, because
they target people as well. And I've seen this firsthand. Mm-hmm. Like, people would come around from the local area and they would start trying to sell you weekend courses. I had friends that went to these weekend courses. They came up to me after the course. They go, oh, like, I'm going to be a sports chiropractor, like how you want to be. That's what they said to me, because everyone knew that I was a powerlifter. Everyone knew I was a coach for 10 years. So I have a very similar background to you, Marv. And I was like, Whoa. What did I saw the photos. Did you do anything else apart from K-tape? You know,
Yeah.
so it's like, so you do K-taping and they call you a sports chiropractor. I'm like, fuck off, man. That's just not what it means. And that's not really how I perceive it. If you're going to put sports in front of your name, I expect you to understand biomechanics. And that's what I said to these guys. I said, look, I'm not so much caught up in dealing with athletes as I am in taking the principles that makes athletes great and applying it to general population. It literally works across the board.
How I look at things is everybody's an athlete in the sport of life. So the principles apply no matter if you're a professional athlete or you just want to play with your kids. Like principles are principles. The biggest compliment I get is you're not a traditional chiropractor. Like that's my goal by the end of the first visit, so them to stop and be like, this is not what I expected, or this is awesome, or this is so different.
Yeah.
Like,
Yeah. Stephen gets that too. All the time.
Like that's my goal. Like that's when I know I did a good job. Like people trip out. We have it's a tiny gym. Like we're hoping to do some stuff in, but like, they're like, you have a squat rack? I'm like, yeah.
Do you get people coming being like, oh, my last chiropractor, like Stephen can talk to this, hey, you get this all the time, Steve. My last chiropractor, did this. I can't believe you're doing da-da-da-da.
It's always funny when somebody comes from a straight chiro. I had a couple of patients come with their printed up subluxations list. Because where I went to school on the West Coast, the main campus in the middle of the country is very straight, and they have the most graduates. I will get calls of, hey, I'm the only one in the area who went to this school. And every time I get that phone call, I'm like, oh, okay. All right. I'm going to get a subluxations list, or I have a locked facet joint. And I'm like, I mean, at one point you might have.
Yeah. Or the Titron scan with all the colors. You literally just said that last episode, Stephen. You're like, a patient handed me a Titron scan. Yeah. And you're like, oh, I don't need that.
Yeah. They put it on the phone. They were like, I got this. And I was like, oh, you can close that. I don't need to see that. They're like, are you sure? And I was like, yeah.
So I go, 1 Mississippi, 2 Mississippi, 3 Mississippi. Okay, thank you very much. You can take that back.
Oh, I like it. You're polite. At least you're polite. I like it. Well done. Okay, Dr. Marv, here's the thing. I need 2 answers out of you, okay? This is I'm bringing it to a point, man. I need 2 answers out of you. How does spinal manipulation impact sports performance? And then number 2, do you use the S word? And you can explain that if you want in your clinic.
Hell no to the second question. I've never used that word. Even in school, I would refuse. Different strokes, different folks. I used to be really headstrong starting out of explaining why the biomechanical model is superior to bone out of place model. And I would talk about, magically going in and out, but I don't do that anymore. And, people will eventually ask me, but like, that was just my ego. I think of trying to tell them why I'm different and better, like let my treatment and my caring and my care plan speak for themselves. Typically, people will start to ask me if they come from a straight chiro background or their parents are chiros, of, well, what do you feel like it's this? And I'm like, all right, well, now that we have rapport, we can have this conversation versus right out the gates. Everything you've been taught before is bullshit. That I don't do that anymore.
Yeah.
Do chiropractic adjustments or spinal and extremity manipulations adjust sport performance? If only somebody on this podcast did an entire thesis on this, we would know that what I'm about to say is true, right? If only that had been done. Well, if you look at physiological, neurophysiological responses, you're doing everything from improved joint function to improved range of motion. You're decreasing pain sensitivity, improving pain threshold, decreasing inflammatory markers. You're getting a nervous system response, improved reflexes, improved, response period. You're getting improved force output, both globally and locally. I mean, that study just came out with adjusting stroke patients. Their foot drop improves, improved proprioception. That might be important if you have, I've got a guy who's planning to squat 900 pounds in a couple weeks, and having proprioceptive awareness is probably important. And then again, people hate on placebo, but placebo is awesome because I put my hands on somebody and they may or may not have gotten the pop sound. Like I tell them, it's nice to get the pop sound. Let's be very realistic, but we don't have to, which is why I like trying to do as many objective pre and post checks with measuring a leg raise and measuring it again. I think that's important, but it would be hard to argue that manipulation does not improve sports performance. But then again, you need to know when and where it's appropriate. And if somebody thinks it's the secret edge, fantastic, because I just gave them more armor to quote unquote go into battle. If they go, man, every time I get adjusted, I just do better on the platform, or I have a better rugby match, right? I was at a rugby banquet for the team I treat here last night, and they'll all come in the day before. You better believe it. Now, half the time I'm like, I need you to sign this saying I'm not telling you to play, but let's try and figure it out. It would be hard to argue that it doesn't.
That's a great, really, really good answer. Definitely going to use that as a clip, because I love how you covered each of those elements. And, on one of the podcasts I said, we need to look at the research around, foot drop or elbow reaction time or reduced step reaction time in elderly people or stroke patients. We need to look at this research and say, hey, maybe chiropractic has a place in these hospital rehabilitation centers, and the first comment, boom, minute after I put it up, are you saying you should be adjusting old people's necks? First thing that came up, and I'm just like, man, it's not lost on me that, we don't have context all the time on social media, but sometimes you put things out and you kind of you just hope people are using their brain. But it's just there are a lot of people out there that hate chiropractors and they can't separate the intervention from the profession. And that's really the issue, because we've got more and more research every single day on the intervention. A lot of the old way of thinking, the philosophical way, the subluxation model, the innate intelligence, restoring nerve flow, that model those types of people are becoming less, and fantastic forward-thinking, evidence-based practitioners such as yourself and Stephen, chiropractors, are becoming more, and it's fantastic to see that. Like, that's a positive thing. And the same thing is happening obviously with osteo. But to throw to you real quick, Rob, how do you deal with people you come up against in your university situation that have really strong opinions that you feel may be outdated or maybe based in an old philosophy? How do you juggle that? Because I dealt with that. I had a hard time with that. I'm sure Marv would have had a hard time with that as well. When you're a headstrong person, you're reading a lot of research, you're talking to a lot of people, then you go to school and your professor says something else. It's like, what are your thoughts on that?
Well, it's taught me a lot about myself. That's the main thing, isn't it? Not whether you win an argument against someone else. And I first got in contact with you, didn't I, about this confusion of people having their thought and they can't understand anybody thinking, and then they lash out at people. So it's all about how it comes from you. So one went into it quite headstrong and think, well, this is what I believe. And then you start butting heads with people. So the main thing is just changing me and they're saying, hang on, let's listen and see why this person is saying this. But then every now and then you get one that basically, because you're a student, they basically shush you down. So the only way around that is to argue with them and become as bad as them. So yeah, it's really complicated. It's really confusing because you're trying to take in all this information and then you're reading these books off people. For example, like you might read a Stuart McGill book, and it might be, you're reading about the lumbar spine, somebody who's done like a 35 years study and covered it as very evidence-based. And all it takes is one tutor that thinks he's God to say, that's a load of rubbish. And then some of those students will probably agree with him, because the thing is, an older student as well, and maybe someone who's will come into it a bit more open-minded, whereas you find that people who have trained, say they leave school at 18, they become a physio or an osteo terrible for it, or chiropractor, they believe everything they've been told. So for you to come along and say, actually, that's not true. That bone isn't touching that nerve. You just, when you make that adjustment, you're just increasing cortical drive and you're getting a performance enhancement. You're taking away their identity. You're saying to them, everything you've learned is rubbish. And I'm coming along and I've been doing this a couple of years. I'm going to tell you that you're wrong. So that's why, these tutors and that, they get, really frustrated with you, because it's like you're coming along and you're saying, actually, you're wrong. Whereas when you go into it as an older student, I haven't got a bias. I'm finding out. So I'm not married to one idea.
I like that.
The only thing I am married to is the biomechanics thing, because of, when you've been really heavy and then you've been under load, what difference those things make. Yeah. When somebody said, no, it's okay, you can move, while you say you don't have to keep your back, that that's not true. you know what I mean? You know that that's not the case. So, you know, when you come up against someone who says that.
Start arguing over research, but you've felt it firsthand. You know, it's like the story you just said about your neck. Being a bodybuilder, you've put yourself under load. And I often say, you know, when people talk about biomechanics based on their interpretation of it from a book, it's different than when they talk about biomechanics from the interpretation of feeling the load on every joint throwing you into the ground when you're trying to squat. I was talking with the guys Locke and Aaron the other day, and we were talking about how unfortunate it is Ronnie Coleman. Like, he was a beast. Unfortunate he had all those injuries. Growing up, like, he just blew my mind watching him do that 850 whatever pound squat. Blew my mind. And I remember being like, oh, like, is it worth it? I don't want to injure myself. I don't want to do this. You apply the proper principles, and I was able to squat more than that. I've never had an injury in the gym. Some people say that's a weakness because you've got some people that have all the injuries and they teach from the experience, obviously, like Marv, which is fantastic, and that's great. That's the other side of the coin. I'm almost the other way. Like, I'll put my body through hell. I've flown close to the sun, squatted the most in my country, 400 kgs plus, multiple times, never had an injury. And yet somebody, you know, a 65-pound person with a DPT who's just come out and finished their degree is telling me that I'm wrong. But what I love about what you said is like, hey, the most important thing is to bring it back to ourselves, bring it back to our own conduct, right? So easy when you get into an argument with these people. Like you said, you're threatening their identity. And it's the same thing. It's like, I say this often, but how do you know someone's a vegan or a CrossFitter? It's like, well, they tell you in the first 1 minute. And it's the same thing with this stuff, right? Like, you're attacking someone's identity so it can get very vicious fast. For you as a bodybuilder, 10 years, I've seen the photos. You're in fantastic shape. I can only imagine the amount of work you put into that.
It's just unbelievable. Like, now I think about it, I'm not that person. I couldn't get that angry. I couldn't get that. I can't even believe it. And somebody said to me today, you know, do you wish you knew everything you know now and before bodybuilding? Like, when I look at blood work, when I look at the blood work results now, at the time I was like, what does that mean? Now I know what all of that means. And I said, no, because I wouldn't do it. I'd be too scared to do it now because I know what I was doing at the time. I kind of didn't. But like we were saying about, you know, people come along and they say, this doesn't matter, that doesn't matter. But what really matters is when you've done a particular sport. Like, we were talking about this the other day. I was talking with another student, and we had someone come in and he clearly trained. He was a big chap. And we were saying, like, same as if a power lifter or a bodybuilder, we could both treat a bodybuilder. We could give him exactly the same treatment, but he's going to feel better off my treatment than he is off yours. And there's the talk about the biopsychosocial. There's the social there. So if we get a power lifter and you treat him and I treat him and you treat him the same, he's going to feel better when you treat him. So, because you're a peer. So regardless of what those people say about underload, they don't know. They don't know. And nobody, like, who really knows is going to listen to that. Yeah. They're going to listen to somebody who's been underload. So is there any need to stoop down to arguing with them? Do you know what I mean?
Because even the smartest people in the world say, hey, be wary of strong opinions, or hey, it depends, or hey, it's contextual. So it's like, we are filling up the portion of the research that we don't have. We're filling up that extra with personal experience because we have it, you know, they don't. So it's like, hey, yeah, we could be wrong. I'm never saying I'm 100% right, nor should anyone, I suppose, to a degree. It's very hard to be that arrogant, can be very problematic. Just think you're always 100% right. Obviously, we're always learning. We always need to be pivoting, changing, new research, etc. With Dr. Marv, with all of your treatments, I want to know, how do you cement long-term changes with your patients? What's the key? We're talking about these interventions and modalities, dry needling, the soft tissue, the spinal manipulation, the mobilization, all this stuff. It's all fantastic, but we know that there's a common thread that goes through all of it, which tends to be short-term neurophysiological changes. Tends to be. Not saying it always is. Some people it's different, but that tends to be the research. So if that's the case, how are you cementing long-term changes?
Well, let's talk about acute, then let's talk about long-term, because I think it's important. Like, for acute, you know, Rob calls it MET. I call it PNF. Like, somebody comes in with an acute condition, I am PNFing them. I'm adjusting if necessary, and then I'm PNFing again.
I'm just going to cut out the PN, and so you just, you know, when someone comes in with an acute injury, I'm effing them.
Yeah. That'll be a good clip. Yeah. we might get some views because it's going to be so sensationalist.
Well, you might
versus
get
all
some
this
patience, Marv.
Yeah. Hey,
Oh.
whatever it takes. Yeah, I wish I could PNF. In clinic, I PNF'd everybody. I adjusted that segment, like that region, just for short term stuff because I think it's so powerful. But I'm, beat up. I have to kind of pick and choose, unfortunately. But then everybody knows if I adjust them, I might be PNFing them after. I'm telling them to don't go home and sit on your couch. I need you to walk, do your 10-minute walk after meals. And the exercises I gave you, either they immediately go, even if I'm like up at the time limit and their 30 minutes is up, my next person's waiting. I go, do you feel comfortable doing the exercises that we've worked on for the last couple weeks? Cool. Just do one set of each. So I have them immediately do the exercise that we found was their area of opportunity from the assessment and what we've been working on. For long term, I think, again, and I know people are going to roll their eyes because I keep using this word, but the educating. So somebody comes in with a couple complaints, I'm like, hey, look, if your low back starts getting tight and flaring up, what have we talked about? Get your hips moving, get your core activated. Okay. When your shoulder starts hurting, what have we talked about? Get, shoulder blade control going on, make sure you're breathing properly. Don't don't do the paradoxical breathing where you're, everything's shortening up here. Well, no wonder why your levator scap and scalenes are, on fire. So literally as I am working with people, especially in the exercise part, I'll demonstrate it and I'll be like, okay, like say I'm doing like a 90-90 position from FRC, just name it. People know what it is. I'll say, this is how you emphasize the front hip. This is how you emphasize the back hip. And then like 5 minutes later, I'll be like, hey, so how do you emphasize this hip versus that hip? I'll keep giving them almost quizzes. But then I really focus on, if they have multiple complaints of, like the back thing. Okay, what do you like? I'll literally be like, okay, so your back, you came in, my back was tight. I did X, Y, and Z. Okay, so what have we talked about that you could do on your own so you're not having to wait to come to me to get relief from the treatment that we're going to give you today? Oh yeah, I'm supposed to get my hips going and I'm supposed to get my core active. So like I really try and bake that in. I try not to be condescending because I'm not trying to do that, but I really focus on these are the tools and I harp on nobody comes and sees me 3 times a week. If I'm aggressive with somebody, it's twice a week for maybe 2 weeks.
I love
because
that.
You've got to do the stuff outside of here. Again, I'm sure I would make more money having everybody come in 3 times a week, but 1, I'm cash pay, and 2, over treating potentially or just not helping out. So a lot of it's patient empowerment through them understanding what caused the issue. So one thing I just started doing when I'm doing, if you want to call it a report of findings, is I pull up my complete anatomy app and I literally go through and say this muscle and here's the action and this is why this is causing that pain there. I found that has helped solidify the education portion significantly. I just started doing that within the last 2 months. And people are really like, I thought about the app. And that's when I started doing my exercises. So that's been helpful as well.
No, great answer. Really, really good. We're going to start closing up. And so we've got a few segments to finish up, a few fun segments. They are rapid fire. Okay. So I'm going to ask you some questions. I understand context. I understand nuance, but it's rapid fire. So have a bit of fun with us. We're going to do a legit or bullshit with Dr. Marv. And then I'm going to put you in the hot seat to start with, Rob. So I've got a question for you here. So you've got 3 people, Giles, Gaia, John Gibbons, and Stu McGill. And I'm sorry to put you in this position, but I need you to pick. Yeah. Hire one, fire one, work for one. There's a hard one. Honestly, it's a hard one.
It would be work for Stuart McGill.
Yeah. You got it. You got it.
Yeah.
This next one.
I would say fire Stu because you just can't match that.
The mustache alone makes you a losing proposition.
Yeah, you got to get him out of the running.
But he'd have to be the ultimate mentor, wouldn't he? Hire John Gibbons, but I don't think you could afford John Gibbons.
Yeah.
And fire Giles.
Oh, Giles, guts bowl. Okay.
So I don't think it'd be easy to do work or hire.
He's the man. Okay, I like it. Okay, so your turn, Dr. Marv. So we're gonna, like I said, fast pace, not a lot of context, but a lot of fun for social media. I've got a few questions here. I'll throw it out. I want to Legit or bullshit?
I have to only use one word. Okay, got it.
You don't have to. I mean, you know.
Oh no, I'm gonna do it as a personal challenge to myself because this is my nightmare.
You're gonna love it. You're gonna love it.
Yeah.
I think I made them really easy, to be honest.
Oh man, come on, man. No underhand softball. Dude.
Okay, are you ready?
Yep.
You ready, Dr. Marv? You sure?
Yep.
Sure you're ready for this?
I've been preparing for this for weeks.
Okay, here we go. Are you ready? Static stretching for tight muscles.
Bullshit.
Massage guns.
Oh. Bullshit for what people think it does. That's more than one word.
Dry needling.
Legit.
Using chiropractic term subluxation in clinical practice.
Fucking bullshit.
Putting mics on your patient when you crack them so it sounds louder for social media.
Bullshit times 1,000.
Using x-rays to locate spinal or postural restrictions.
Bullshit times 1,000,000.
Using x-rays as a way of ruling out red flags.
Bullshit. Oh, wow. No. Legit times 1,000.
PNF or MET or METs or any other neuroinhibition active type of stretching. Or
Legit.
Telling patients to stop lifting as a blanket rule for all injuries.
Bullshit.
Chiropractic leg checks.
Bullshit.
Using exercise for rehab.
Legit.
The biopsychosocial model.
Super legit. You need to learn it.
Toggle adjustments.
Bullshit.
The hole-in-one upper cervical technique.
Very special people who believe in that bullshit.
Technique matters regarding injury prevention.
Legit.
The bone out of place chiropractic philosophy.
Bullshit.
Using education in conjunction with manual interventions for all of your patients.
Necessarily legit.
That's it. Well done. Round of
All right.
applause. Round of applause. How do you feel?
That was good. He almost caught me on the one because I kept hearing x-rays and I was like, oh, God.
You hear x-rays and it's just like, boom, fire off.
Yeah.
Hey, it's absolutely been a pleasure having you both on. Is there anything either of you want to say before we close up?
Thank you guys so much.
I mean, as I knew, we could go on and on and on and on. I mean, it just feels like it's supernatural. I barely got through half of the stuff I wanted to talk about, but these types of podcasts are always the best.
Yeah.
Yep.
If people want to get a hold of me, well, I'm in Houston Bay Area, Coastal Performance Chiro. Just reach out to me on Instagram. For my private one is dr.marvinsays.dc. Just reach out to me there. That's where I'm most active. Don't reach out to me on TikTok.
Yep.
I don't pay attention there.
Fair enough.
And whatever I can do to help, anything, just full stop, let me know.
But I've been sharing both of your pages and I'll continue to do so people can go through that if they need to. Otherwise, thank you so much for coming on. It's been a pleasure. We'd love to have you both on at different times throughout the coming season to continue this conversation because there's just so much good content and just not enough hours in the day.
Rob, nice meeting you.
Thanks. Nice to meet you
Thank you
too.
for joining us.
Thanks, guys. Appreciate it. Have a great day or a great
Thanks.
night.
Bye.
See ya.